أسعد الله صباحكم بكل خير. حقيقة يعني بداية الحمد لله والصلاة والسلام على رسول الله، ويطيب لي أن أتقدم بالشكر الجزيل بعد شكر الله عز وجل لجمعية السرطان لمكافحة السرطان بالمدينة ولمديرية الشؤون الصحية على استضافتهم لهذا المؤتمر، ونشرف بمشاركة الجمعية السعودية للرعاية التلطيفية لهؤلاء الزملاء في تنظيم هذه الفعالية. In the next 50 minutes or so, we'll be discussing and trying to answer these questions. Why is cancer pain too important? Is cancer pain treatable? Is it optimally treated? And if not, why not? And then we'll talk and try to address some of the cultural aspects related to pain management and this group of patients, cancer patients. So the first question to be addressed: why is cancer pain too important? Why do you think cancer pain gains this importance? Any suggestion?
Affect the life of the patient.
It affects the life. How about the other types of pain? Do they affect the life of the patient negatively? All of them. But why cancer pain is unique? Why people keep talking about cancer pain? Wonderful. So it's increasing as time goes on, as opposed to the other types of pain, many of which decrease as time goes on. So cancer pain is tough. You can see these two pictures. Both patients are complaining of pain. That patient is having non-cancer related pain, and this patient is having cancer related pain. And you can imagine the toughness of the cancer pain when you consider the other aspects other than the physical aspect of pain. Because in cancer, you have the physical aspect and you have the psychological and probably the psycho-spiritual aspects as well that interact with each other to lead to the so-called total pain. We'll come to that in a minute. But people think that cancer pain is unique not only because of the severity of this pain, but also, as our colleague mentioned, that cancer pain is expected to increase over time, most of the times, especially in advanced cases, in advanced cancer cases. So this is to differentiate between the cancer pain and non-cancer pain. The non-cancer pain is expected to improve over a course of time, while non-cancer pain is expected to worsen. Some people say that cancer pain is meaningless. Of course, we know that there is nothing in this life that is meaningless. Everything in this life is created by God for certain purpose. Sometimes we know it and sometimes we don't. But their explanation of this expression is that the other types of pain are generally protective, and to feel pain is a protective character in the human being. And that's why they are saying pain is indispensable for normal life. To run a normal life, you need the feeling of pain. You need to feel pain to protect yourself, not to harm yourself. Okay? So if you touch something hot, you will reflexly withdraw your hand. And this is protective for yourself when you feel this pain. But they say, when you have advanced cancer and you know that you can't do anything to treat this condition, you cannot do anything to cure it, then what's the point of continuing to have the pain? That's why they call it meaningless. And also, the point that we mentioned, the physical pain, the non-cancer pain is physical in nature, basically. While the cancer pain, there is a physical component, yes, but this is exaggerated and exacerbated by the other aspects of suffering, the other aspects of pain, that is the psychological pain, the spiritual and the social aspects of pain that will interact with each other. All these facets of pain will interact with each other to lead to what is called total suffering or total pain. And they express that by saying the whole is greater than the sum of its part, meaning 1 plus 1 in this scenario is not equal to 2, but it is equal to more than 2. Okay? The other point that makes cancer pain unique and deserves a lot of attention is the fact that it is common. It is a common problem. Cancer pain is a common problem. And this is, although maybe 7 years old paper, but this is a very important paper in my opinion because it covers 40 years of literature. They reviewed all this literature and came up with this data that cancer pain is about 55% prevalent in all cancer patients. While in patients with advanced disease, it's even more prevalent. Almost 65% of these patients in the advanced stages, they will experience cancer pain. And they found that some types of cancers, like gynecological cancers, and more so head and neck cancers, in these categories of cancers, the cancer pain is even more prevalent and sometimes even more difficult to control. So cancer pain is common. And in fact, some authors think that or suggest that almost all cancer patients will experience pain at some stage of their disease trajectory, whether during the diagnosis or during the treatment because of the treatment modalities, including surgery, including chemotherapy, or in the advanced stages. So they will experience some sort, even if it was just due to the procedures for investigating the cancer, they will experience some pain. So pain is associated with the cancer during diagnosis, during treatment, and also in advanced stages. This is another study that shows the prevalence of pain in different end-stage diseases, including cancer. And you can see that cancer is on the top, almost 96%. This is our experience in King Faisal Specialist Hospital in the outpatient setting. And these are the new patients seen in the clinic for the first time. We found that the great majority of these patients were having pain. 85% will present with pain in the clinic. Only 15% of patients will have no pain. They will have probably other symptoms. The question is how severe this pain was. Still talking about our clinic in the outpatient in King Faisal Specialist Hospital. As you can see from this bar chart, that majority of patients were having pain that was moderate to severe, with a pain score of 3 or more, of more than 3 actually, of more than 3. 72% will have pain score more than 3. 3 out of 10. 10 meaning pain that nobody can tolerate, the extreme, the severest pain one can imagine. And 0 means no pain. So we consider from 4 to 10 to be moderate to severe pain. And the mean and median was around 5. So it's quite severe, moderate to severe. The other question that we need to ask ourselves, is cancer pain treatable? We have said that it is too tough, it can be severe, especially in the advanced stages. So the question is, maybe this pain is not treatable. And this is unfortunately what a lot of people think. The good news is that, alhamdulillah, cancer pain is treatable. And actually it is treatable following relatively simple methods. That is the WHO analgesic ladder that you will hear about a lot in this symposium. So about 90% of cancer pain is treatable following this method. That is basically based on pharmacology. In fact, the literature, there is a lot of literature. This figure is not arbitrary. The WHO took this figure from reviewing all the literature, and it ranges from 77 to 100% as per different papers. So they said about 90% of cancer pain is treatable following the WHO analgesic ladder. So very simple. It's a 3-step ladder, and you will hear about it later in this course. So, is cancer pain optimally treated? We know now that it is relatively simple to treat it, and it responds to treatment. So, it must be treated well worldwide. The answer is two bad news. Cancer pain is under-treated globally, worldwide. Of course, with great variations between different countries. This is according to the WHO. 80% of cancer patients have no access to pain-relieving drugs required. 80% of the people on this planet, they don't have access to medications to treat cancer-related pain. And mind you, the medications for treating cancer pain are very cheap in general. So in spite of that, people are not getting access to these medications. Why is that? So, and let's take some examples. Now, Norway is a developed country. So let's see what happened when they tried to study the problem in Norway. They did a nationwide survey, in this example, and tried to see whether cancer pain is treated well or bad in inpatients. We are not talking about patients in the community. We are talking about inpatients. So what did they find? They found that 37% of inpatients were undertreated. 30% of patients with moderate to severe pain were on no opioids. Mind you, opioids are the mainstay treatment for cancer-related pain. The most important drugs to treat cancer-related pain are opioids. So 30% of patients, almost 1/3, with moderate to severe pain were on no opioids, and 7% of patients, inpatients, remember, they are inpatients in Norway, with moderate to severe pain, they were not receiving analgesia at all. One might ask himself, maybe Norway is an exception, and Norway is a bad country in health services, and in treating cancer pain is an exceptional country. This shows the per capita consumption. They ranked the countries all over the world in terms of the per capita morphine consumption, and per capita morphine consumption per patient is considered one of the good indicators to tell us whether a country is treating cancer pain properly or not. This is one of the best indicators we have. Norway ranks number 11, as you can see. Is country number 11. So Norway is on top of the list, and we rank 85. Very unfortunate and very sad. And this, the implication of this is what? This means that a lot of our patients are suffering. A lot of our patients experiencing and suffering from cancer pain are suffering unnecessarily when we can help. This shows the morphine equivalent per capita consumption in the Arab world. Again, of course, you know that the WHO is dividing the world into regions. There is the EMRO region, that's the Eastern Mediterranean Regional Office, to which we belong. And in 1980, the per capita was 0.24, very low, extremely low. In 2010, it improved, but it's a modest improvement. It's 7.1 milligram per capita. While the global mean was in the 1980 about 2 milligrams. In 2010, it has increased to close to 60 milligrams. So compare between the global mean, 60 milligrams, and the EMRO mean, 7 milligrams. And then look at the per capita consumption in the different countries. Almost all are circled in red. It's very sad, very low figures, very unfortunate. This is the morphine equivalent per capita consumption in other countries in which palliative care services have been more developed. You can see in Canada, 753. Compare this to the figures that we have. In the IMRO, 7 milligrams. 7 milligrams compared to 700 plus. USA, almost 700, and so on and so forth. So the gap is huge between different countries in the world. And we said in the beginning that cancer pain is undertreated worldwide. But there are countries worse than the others. This map shows, it's an approximate map, showing the development of palliative care services worldwide. And Saudi Arabia, you can see there, the red color, is a country with localized provision of palliative care. So we have palliative care in some centers, big centers, but many other centers, they don't have palliative care services. In fact, cities, they don't have any sort of palliative care services, even a small program. There is nothing like that. So I think there is a lot ahead that we need to work on. This again shows some comparison between what we have and what other people have in terms of palliative care services. This is the ratio of full-time palliative care physicians to population. If we take Sweden as an example, there is one full-time physician, palliative care physician, to 30,000 population. In Italy, 1 to 58. In Saudi Arabia, it's 1 to 1 billion people. So we have a great deal of lack of resources. And this also shows the ratio of dedicated palliative care beds to the population in million. In Sweden, it's 72 to million population. UK, 53. France, 27. Italy, 19. And in Saudi Arabia, it's 1 bed to 1 million people. So this shows you the gap between what we have now and what we have done and where we should be. Now, the other question is that, is this problem going to resolve itself, or in the future, is it hopeful that we are going to tackle this problem with the current resources and efforts, or is it going to worsen as time goes on? This chart shows the future health, the projected global deaths for selected causes of death between 2002 to 2030, estimation. And you can see on the top that cancer cases are expected to rise more than anything else. And this means what? This means that more cases with cancer-related pain. So we expect the problem to increase in magnitude in the future. Forget about everything in this busy table except the upper row, which tells you how much improvement we got over the years in treating cancer in radical terms, in curative terms. See, they compared the 1974 to 76 with 1983 to 85, and then with 1995 to 2001. And you can see the figures. Very modest improvement in treating cancer in radical terms. This is the 5-year survival. So still, a lot of cancer patients, for them there is no curative treatment, there is no radical treatment. This means what? Most of these patients will have their disease and will die with their disease. And this means also a lot of suffering associated with that, including cancer pain. We know that cancer is a disease of older people. And as time goes on, we are getting older people more and more. So the population, yes, is young at this stage, but in the future, the projections are that we are going to get an aging population. This is a global problem. This is the population pyramid of Saudi Arabia a few years ago, and as you can see, most what is expected in the future is to be like this. So more elderly people, and in this population, of course, the incidence of cancer is higher. So we need to be prepared for that. And this shows also the life expectancy of Saudis in the 70s. The life expectancy was 50 years in the 70s. And in 2010, it increased to 77 years. So we are going to get aging older population more and more. So nowadays we are dealing with the tip of iceberg, and if we don't act quickly, then we are going to face the roots of that iceberg, which is much huger and larger. Okay, so why are we not treating cancer pain properly if it is easily treatable? It's not costly. We said the medications are relatively cheap. Why are we not treating it properly? What's the problem? These are the problems categorized according to different categories as per the different available literature. Barriers related to health professionals, barriers related to patients, and barriers related to the health system itself. So, as regards the barriers related to health professionals, which in my opinion are the most important barriers. So, the most important barriers that prevents us from treating cancer pain properly are us. We are the biggest barriers as healthcare professionals. First of all, inadequate knowledge. And that's why we need to have a lot of these conferences, a lot of these scientific gatherings to raise and improve the awareness about cancer pain and how to assess it and treat it. The other problem that lies in us is the poor assessment of pain. If you don't assess pain properly, how are you going to treat it properly? And also, there are other concerns related to regulations. Sometimes we have some knowledge about, or fair knowledge about how to treat cancer pain, but we are scared about the regulations. If I start, because you know, the opioids are under control, controlled medications. They are not like the other, medications. So they need some. There are some regulations. Some of us are exaggerating the fear of these regulations. I'm going to sign the different signatures and might be questioned later on. So they hesitate from using these drugs and keep the patient suffering unnecessarily. Some of us have concerns about side effects. If I give my patient the right medication, the opioids, they might develop respiratory depression, for example. And then we refrain from giving them these medications because of the fear of side effects, which is unfounded side effects. It's extremely rare for a patient treated for cancer pain with opioids in experienced hands to develop respiratory depression. Extremely, extremely rare. Sometimes we fear the problem of addiction. If I start prescribing opioids to my patient, maybe they will become addicted and I'll be in trouble. We'll see later on whether that is founded or unfounded. And sometimes we fear tolerance. We'll say, okay, if we start to give the patient opioids from now, what should we give him 1 month from now, 2 months from now, 6 months from now? Then there will be nothing effective to treat this pain. Again, this is unfounded. Then some barriers related to patients themselves. Reluctance in reporting. Some patients do not report their pain, whether because they are stoic, they just tolerate it, and sometimes they fear if they start to tell you about the pain that you will be focused on pain and forget about treating that disease itself. So they want the physician to focus and concentrate on treating the disease itself rather than the symptoms. And sometimes they believe that if they report pain, this is a reflection of disease progression. So as part of denial, sometimes they will say, no, we are okay, I'm fine, we are okay. When in fact they are suffering and they are experiencing pain. And here comes the very important role of the impeccable assessment of the pain. And sometimes our patients also, not only the health professionals, our patients might feel addiction because they know opioids, that these are medications used by addicts and they lead to addiction. So maybe sometimes they feel the addiction, and sometimes because of the side effects of medications, if we don't explain the side effects well, and if we don't treat the side effects like constipation, they cause nausea and vomiting in the beginning especially. If we don't explain to the patients, and if we don't treat these side effects, they might stop using the medications and say, okay, yes, I'm having pain, but these medications are causing me other problems. So they are not compliant. So these are sometimes, especially in our culture, Islamic background, some patients will say, no, these are bad medications. Of course they are bad if they are used by people who don't need them for recreational purposes. But for medical purposes, there is fatwa that it is permissible to use these medications to treat cancer pain. So we have to explain to the patients. The third group of barriers against treating cancer pain properly is related to the health system itself. Unfortunately, the health system most of the times gives low priority to cancer pain treatment. It's not something showy, the cancer pain treatment. It doesn't involve huge machines, with multi-million, cost, and it's very cheap medications, and it doesn't, it's not eye-catching. And that's why, unfortunately, it's not put high on the agenda. Sometimes the regulations regulating the use of opioids are too restrictive, and that's another barrier, unfortunately. And sometimes opioids are basically unavailable in some health institutions, either in enough quantity or also the formulations. They might have parenteral medications, but they don't have the oral formulations of medications, for example. Now back to the problem of addiction, because a lot of people, the minute you start talking about opioids, they will say, oh, addiction. Biggest field is addiction. Let's see what the literature has to say about this. These are two important studies done. In the first one, almost 12,000 inpatients who received one opioid drug or more, they only found 4 cases of addiction identified. And this was published in the New England Journal of Medicine. In another study, 550 patients who were on morphine for more than 22,000 treatment days. Very good study. They only found 1 case of addiction. So it's extremely rare. If we use it in experienced hands. We don't want each and every doctor on earth to start using opioids haphazardly. No, there should be some training. So what's the solution of this problem? It's a multifaceted problem. The barriers, as we have seen, can be related to the patients, can be related to the healthcare professionals, and can be related to the health system. The solution, as per experts, is through this triangle. Make drugs available, educate people, and modify the policy to be friendly to cancer pain management. And the most important, if you ask me, what is the most important aspect of this angle, of this triangle, I will say it's education. I think education is the most important aspect to overcome this problem. Now we'll move to the cultural aspects related to cancer pain. the experience of pain in itself is old, and it's as old as man's history. It's something created in this creature, that is the human body. So the feeling of pain is as old as man's history. However, the ways in which people conceptualize and report pain and treat pain may vary according to cultural differences. We'll take one example to show you or to emphasize that. In this study, they compared patients, a homogeneous group of patients in Vietnam compared to patients in the USA. These patients, they compared the pain in these two groups and the use of opioids. And the group of patients were patients in the first week of injury experiencing pain who received fixation of the femoral fracture. So even the type of fracture was the same. It's a femoral fracture. They received the same procedure, fixation of that fracture. And in the first week of injury. What did they find? The Vietnamese patients were receiving less than 1 milligram of morphine equivalent daily dose. So let's say 1 milligram. And the patients in USA, same condition, remember, receive 30 milligrams per day. Okay? 1 versus 30. And they asked the patients, were they satisfied? Were their pain controlled? 8% only of the Vietnamese patients reported inadequate pain control. Only 8%. While 80% of the USA patients said they were not happy. Pain was not controlled. Although they used how many times? As much as 30 times more than the dose used by Vietnamese. So the authors believe that there are cultural factors involved in this discrepancy. Another study, they found that Arabic-speaking nurses gave pain ratings that were better matching those of Arabic patients. They belong to the same culture and they speak the same language. So they are assessing the pain of the patients in a much better way, as opposed to nurses who are not speaking Arabic, the language of the patients. The Chinese patients may understand a vertical presentation more readily than a horizontal one. This is when you design the pain assessment tools. Because the Chinese is read vertically downward, from right to left, this way. So when you try to create a tool to assess pain, you need to keep that cultural aspect in consideration. And this is similar also to the Arabic language. We have to keep it in mind that Arabic language is written and read from right to left in a horizontal way. And that's why when we assess this, when we create this tool to assess the pain, we keep that in consideration and we start with the assessment from 0 on the right side to end by 10, that's the worst, the severest pain on the left side. We all know that pain is what the patient says it is. Because we don't have a tool that's very precise and it's like something like imaging that tells us whether or not this patient is experiencing pain. We have to believe what the patient says. So pain is what the patient says it is. However, remember that not every patient will tell you whether or not they have pain, and sometimes whether or not their pain is severe or moderate or not. Take an example, Chinese patients, for instance, might not complain of pain and might not want to bother the nurse to ask for pain medications. They feel that it's, out of politeness, it's just to keep silent and keep, suffering, not to bother. So this is a cultural aspect that affected their expression of pain. This man belongs to the Poko tribes in Kenya, and they regard stoicism in the face of pain as honorable and the expression of pain as shameful and inappropriate. So if we just, wait for them to volunteer and tell us whether or not they are in pain, we are not going to get anything and they will continue to suffer. So we have to be proactive and ask patients positively. The meaning of pain as influenced by culture may affect the pain threshold and tolerance. What do we mean by pain threshold and pain tolerance? Pain threshold is the vocal report of pain when first recognized by the subject. So if I have a subject here, patient, and then I started to put some pressure on the patient or use a noxious stimulus very gradually. In the beginning, the patient will not feel any pain. At some stage, the patient will start to feel some pain, but it's very tolerable. So when the patient tells me that, yes, there is some pain right now, this is called the threshold. Okay? And then the pain tolerance is when the patient cannot tolerate it anymore and will tell me, oh, now you have to stop. That is the tolerance. And the cultural background is believed to affect these two, the threshold of pain and the tolerance of pain, these 2 points. Now back to the culture of the patients we are dealing with. We are treating patients in Saudi Arabia. So when we talk about the culture, we talk about the culture of Saudi patients. And what is the definition of culture? You will find many definitions to define culture. But Banks and Bags, these are a couple, husband and his wife, who did a lot of work in the social sciences, and they wrote books and published a lot of papers. And they defined culture as the ideations, symbols, behaviors, and values and beliefs that are shared by a group of people. Okay? So this is the definition of culture: ideations, symbols, values, and behaviors and beliefs shared by a group of people. So if we say, how would you describe the Saudi culture? What is the most important factor that shapes the Saudi culture? I think it's very clear on the flag of the state. That is Shahadat la ilaha illallah wa Muhammad Rasulullah, which means the religion, Islam, is shaping and forming, is the most important factor. Of course, there are other factors, the economical factors, the education, all these are playing their role, but the background that shapes the culture is the religion. And this is one of the verses, translation of one of the verses in the Holy Quran. قل إن صلاتي ونسكي ومحياي ومماتي لله رب العالمين. كل شيء في حياة الإنسان يعني لله سبحانه وتعالى. Say, O Muhammad, verily my prayers, my sacrifice, my living, and my dying are for Allah, the Lord of all that exists. Now, the meaning of pain is one of the very important things, especially when it comes to cancer-related pain. Because you remember in the slide that we said, in the Western literature they say it's a meaningless, and that exaggerates the suffering of the patients. Sometimes they go into what is called existential suffering. They don't know why they are suffering like this. Why are they having this type of pain that they believe is meaningless? But here in our culture, people find meaning for that. And this was guided by the sayings of the Prophet ﷺ, who said, this is a translation of his saying, no Muslim is afflicted with any harm, but Allah will remove his sins as the leaves of a tree fall down. So there is a positive meaning in that kind of suffering. The patient will perceive it that way. And this is very, very healing to the patient. He also said, no fatigue, no disease, no sorrow, no sadness, no hurt, nor distress befalls a Muslim, even if it were the prick he receives from a thorn, but Allah expiates some of his sins for that. He also said, strange are the ways of a believer, for there is good in every affair of his, and this is not the case with anyone else. If he has an occasion to feel delight, he thanks Allah, and that is good for him. And if he gets into trouble and shows patience, that is good for him too. his suffering. The patient, if he shows patience, will be rewarded for that. And even for somebody who has no sins, like the Prophet ﷺ, he also felt pain at times. So what's the meaning? Allah subhanahu wa ta'ala will raise his ranks. He will be raised and his ranks will be raised because of his patience. Does that mean that as Muslims we should not ask for treatment? We should just endure this pain and just ask for the reward from Allah? The teaching comes from the Prophet ﷺ. He says, seek treatment as the one who created the disease created the remedy. So we are guided by the Prophet ﷺ, who asked us to be patient. He asked us also to seek treatment when it is available. So the cause of pain in the Islamic culture, of course, first of all, we believe in predestination, al-qadr. So something is written, whatever is written by God has to happen. It is written by Allah, then it has to happen. This is the belief or the faith, in qadr, predestination. But at the same time, we believe also that there are means through which the pain shows up. The physical means, the materialistic means through which the pain shows up. Like cancer, like trauma, like inflammation, and so on and so forth. All conditions that cause pain. These are the means through which the pain is showing up. Now, we'll talk about some of the things, and this is important for all health professionals, but especially for nurses, to consider and keep in mind. This is especially for non-Arabic speaking people who are not well versed probably in this culture. If you ask the patient, how do you feel today? And the patient says, Alhamdulillah, thanks God. This doesn't necessarily mean that the patient is not in pain. The patient might be in severe pain and is saying, Alhamdulillah, when you ask him, how are you feeling today? Okay? So keep that in mind and be proactive and ask specifically about pain. Patient expects swift action to control pain. Patients are not healthcare professionals. They don't know that these are opioids and you have to go and maybe ask pharmacy to get the medications and then ask other nurses to witness the drawing of the right dose and administration of the right dose. They don't ask all these details. They think that when they tell you that I'm in pain, severe pain, then immediately on the spot you will go and bring the medication and administer it. If you delay it for 10 minutes, because of course you have to do certain things, they might be very unhappy and they consider this as carelessness. You don't care for them. So we have to explain to the patients what are the procedures we are going through, and we have to show them that we are caring and we are taking this very seriously. Patients, some of our patients, although maybe not majority, maybe a small proportion of our patients might be very stoic, and then we have to ask them and dig further and find out whether or not they are suffering from pain. Patients' expression of pain may be exaggerated at times. Why? Because sometimes they might be looking for cure. And when they tell you, you give the right medication, give the right dose, and the patient is still saying, I'm in pain, nothing is working for me. And when you try to increase the doses further, the patient goes into toxicity. So this patient maybe one of the possible explanations is that patient is looking for cure. So what do we need to do in these situations? We need to discuss with them. We need to give them more time to talk about their pain. What do they mean exactly? So they need us to sit down and start talking more and more about the pain. Sometimes the patient is angry because of one reason or another, or blaming the healthcare professionals or the hospital of not doing the right thing or the right time, and expressing their anger by saying, I'm in pain. All the time, I'm in pain. So keep that also in mind. And the solution for all this is by discussion, by giving them time. So time is the key. Patient may have unduly high expectations of analgesia. Sometimes, some of the patients with cancer-related pain think that the medication should be like curative of pain completely, 100%. In reality, this doesn't happen. And sometimes some of the health professionals keep saying that we should aim for no pain, no pain for all patients. In reality, this doesn't happen in cancer-related pain. What we should aim for is to reduce the pain as much as we can to a level that's not bothering the patient. The patient can live with that very little amount of pain. And also some patients think that the good medication is the medication that treats the pain once and forever. You give it to me today, and then I will not need any pain medications later on. We know that it has got a half-life and it will work for some time, and then the pain recurs back if we don't treat it, continuously around the clock. So we have to explain this. The solution for this is explanation. We need to educate our patients, explain to them what is the objective of their treatment, what are our goals, and all of these details. Patients may avoid strong analgesics for the fear of addiction or religious impermissibility, and we have talked about this. We need to explain to them that it is absolutely permissible, as per the fatwas that we have, to use these medications for medical purposes, and that the addiction is an unfounded misconception. It's a really misconception, and it's not true. A child may be afraid that admitting to pain will result in unpleasant things, like receiving more injections, and so they want to avoid that, and they endure pain. Sometimes, some of these children, especially children with cancer patients, have great wisdom. You find them like very mature adults. And some of them will endure pain and be patient just to please their parents and not to make them, worried about them. It's really amazing. So we have to try our best to help these kids, who are suffering too much, and try to be proactive and find out if they have pain, and we should help them. In our culture, boys may regard crying with pain inappropriate, so maybe they might be more stoic and trying to hide their feeling of pain. This is the fatwa from Samahat al-Mufti, and it is very clear that we can use these medications to treat cancer-related pain. Finally, this is a case scenario, a real case scenario that we encountered. There are a lot of scenarios, but this is, one of which a lady, 65 years of age, with endometrial cancer. The disease was locally advanced. The patient at that time was still receiving chemotherapy, and she was on opioid infusion for pain. The patient was receiving 0 to 1 breakthrough analgesia per 24 hours. Breakthrough analgesia is a rescue medication given to the patients on as needed basis if they feel pain at any time, at any point of time. So, and this breakthrough analgesia, we take it, palliative care physicians, we take it as an indicator whether or not the pain is well controlled or not. Okay? So if the patient, for example, is requiring in the 24 hours 5, 6, 7 breakthroughs, we feel that the patient is not controlled. That's why she is asking for too many rescue medications. But if the patient is requiring 1 to 2 rescue medications in the 24 hours, we feel comfortable. We think that things are all right and pain is under control. So this lady was receiving almost nothing in the 24 hours. And whenever you go to ask her, she will say, oh, I'm in too much pain, nothing is working for me, I'm still, it's too bad. So when the doctor visits the patient, she complains of poor pain control. The nurse and the patient sitter, who was a young lady, disagree with the patient's views. They will shake their heads like this. She's all right, she is fine. Pain is controlled. Without her hearing them, just from behind, they will say, no, she is fine. Didn't change anything. And the patient says, no, doctor, are you in pain? Yes, I'm in too much pain. No improvement. So what do you think was the reason? Why this lady is saying that? from all what we have said. In fact, this lady was looking for a cure. She's an illiterate lady, 65 years old, and she was able to feel the mass in her lower abdomen. So she was focused on this mass. So pain for her means this mass. The mass is still there. Otherwise, the physical pain is not there. She's very comfortable. And that's why she's not asking for extra medications. Okay? So when we digged further in history and sat down with her and tried even to speak her own accent, she opened up and she said, yeah, my son, this disease, put your hand here. It's here still. It's not going away. So we realized that the pain is very well controlled, but she wants the disease itself to be removed. So that emphasizes further the importance of talking with the patients and giving their time. Thank you very much.